All right, we're going to go ahead and get started. Welcome everybody to the presentation this morning on CPC Plus and Oregon Practices Application webinar. We are going to certainly save time for questions at the end of the presentation today. So you can type those into the questions pane any time during the presentation. If you think your question might be answered, you might hold it. There's a lot of information our presenters are going to go through today, but if you want to make sure you don't forget it, feel free to type it in. We'll organize those and make sure we address all of those at the end. Everybody is on a global mute today. There are 70 attendees in this presentation and growing, so everyone will be on mute, so typing in your questions is how we'll be able to take those today. If you have any technology issues, this is Kate. I'm the program director here at QCore. I'm helping to moderate the webinar, so feel free to put those into the questions panes or also send me a chat. I would be happy to help you if you're having any issues. My favorite question, and one that I know everyone has, yes, a recording of this webinar will be available after the presentation today along with the slides. Anybody who's registered will be sent a link to the recording so that you can share it with your colleagues, and that'll be up by the end of today. Or you can visit the website where you registered, and you'll find that later today if for some reason you missed the email. I'm thrilled to go ahead and introduce our presenters today. Dr. David Dorr is a professor of general internal medicine and geriatrics at OHSU. His expertise is in care management, coordination of care, collaborative care, chronic disease management, quality, and the requirements of clinical information systems to improve and support these areas. His current concentrations are transforming outcomes for patients through medical home evaluation and redesign, or TOPMed, risk stratification in primary care, and further dissemination and evaluation of the Care Management Plus project, in addition to CPC going on right now. He is interested in policy and payment reform to help provide better coordinated patient-centered care and support efficiency in the healthcare system. We also have Dr. Ron Stock, who is a geriatrician, family physician, clinical health services researcher, and currently a clinical innovation advisor to the Oregon Rural Practice-Based Research Network, or ORPRN, and the Oregon Health Authority Transformation Center. He's currently an adjunct associate professor of family medicine at OHSU. Before joining OHSU in 2012, he served as Executive Medical Director of Geriatrics and Care Coordination Services and Medical Director of Education and Research at Peace Health. Over 2 decades with support from public and nonprofit grants, he has dedicated his career to improving the quality of healthcare for vulnerable populations with complex care needs, focusing on redesigning the primary care delivery system for vulnerable elders using an interdisciplinary team model. He's been past faculty to the Oregon CPC initiative and has participated as a member of the Institute of Medicine Best Practices Innovation Collaborative on Team-Based Care. So we are definitely in good hands, and I'm going to hand things over to Dr. Dorr and Dr. Stock.
So good morning, everyone. Hopefully we're all online here. I'm looking at Melanie and Kate, let us know. But this is Ron Stock, and on behalf of my colleague and good friend, Dr. David Dorr, welcome to this webinar this morning. I feel sort of privileged to be here, thinking this has been really a great opportunity for us to talk about this new program and moving forward with the previous initiative with the Comprehensive Primary Care Initiative. I also want to acknowledge the team here at Care Management Plus in ORPRN for the work that they've been doing the last 4 years in supporting through the TA for the CPC initiative, and also helping us put together this webinar and the slides. It's really been a terrific team. Kate and the folks at the PCP, Patient-Centered Primary Care Institute at QCore, thanks for hosting the webinar today. We'll advance the slides here. See if this will work. Click on the screen. Oh, okay, there we go. Oh, well, let's go back. So we're going to move forward this morning with the assumption that I'm going to start off and just do an introduction of what CPC Plus is, and it's going to be pretty high level. We're coming into this with an assumption that most of you have already read the briefs and read up on a fair amount of the materials that CMS has put out about the program. But we want to make sure that everybody's kind of on the same page, so it'll be a pretty high-level CPC Plus. We'll dive into about 4 kind of particular topic areas during this presentation. We also want to share with you the Oregon CPC experience, and so that you can also not just hear about what the outcomes have been over the last 4 years, but also hear from some of the participants and the practices in this state. We'll cover a bit about the payers, payer information, and we'll have Dr. Jim Rickards make a few comments. We'll walk through the eligibility requirements and the application, and then finally we're going to be watching the clock closely, so we make sure that we have plenty of time for questions from you all, and would encourage you also, if you have questions as they come up, to even write them in the chat box so that we have an idea of what kinds of issues and questions you'll have. You get a special thing today is you get to see the driver diagram, that big target on the right, for all of those QI or quality improvement methodology junkies out here. I'll encourage you to take a look at that when you have some time. We aren't going to go through that this morning, but you'll note that this is a driver diagram. It helps in one picture just describe what this program is trying to accomplish, with patient and caregivers in the middle, all working toward accomplishing the triple aim. So congratulations, Oregon. So we were one of 14 regions and states to be selected to participate in this initiative, and I believe that all 7 of the original regions that were participating in CPCI, or I guess we're now calling it CPC Classic, that are also part of this program. As many of you know, this will be a 5-year model program beginning in January. It's the largest primary care model implementation in U.S. history, and the idea that this would be focused on primary care is really exciting. Up to 5,000 practices are hoped to be signed up for this. I think the goal is to try to get 2,500 practices in each of Track 1 and Track 2. Up to 20,000 physicians and 25 million patients will have access to this model. Across the state of Oregon, we have 15 payers, and we'll talk a little bit about that and their role a little bit later in the webinar. But it's very exciting that so many payers signed on to participate with this in the state. So in the typical QI methodology protocol, we always want to ask the question, what are we trying to accomplish? So, first of all, this is a major delivery system reform effort, again, addressing the triple aim. Secondly, this is a program that will advance care delivery and payment together. For many of us, we've been working at trying to improve care delivery for a couple of decades. And we know we have some best practices that work, but the opportunity to actually create a program that ties the payment to the care delivery, as well as begin to measure whether we're actually accomplishing what we're aiming to accomplish, is a really exciting way to move forward with this program. In particular, this program addresses complex care needs of the population in our state. And so, again, this is a bit unique in that the focus is really on a lot on the complex needs, particularly in the Track 2 setting. The third effort that we're trying to accomplish is that we realize that the the spectrum of where practices are at is broad. We know that for some of you out there, you're really just sort of putting your toe in the water and thinking about this, haven't been as activated around redesigning your practice, and so this may be an opportunity for you to really take that next step. For other practices, but particularly those practices that have been involved in CPC Classic, this is you're at the other end of the spectrum, really wanting to take us even further. So for that reason, there are two tracks in this model that will be supported. So really recognizing that practices are all in different places and hopefully be able to accommodate where you're at currently. I added the fourth objective with what we're trying to accomplish, and particularly in Oregon, is to begin to align all the different programs that are happening and reform efforts that are happening in Oregon, particularly aligning Medicaid program and the development of the CCOs, to begin to align the payment and quality metrics and the delivery in Oregon. So the first question for you all really is to, or one of the first questions for you is to decide whether you're going to participate in track 1 or track 2. Track 1, as I mentioned, or for those who may not have been, practices that may not have been as actively redesigning your practice or involved in new payment methodologies, this is really a pathway for you to begin that journey for you. And for many of the 67 practices in the CPC Classic, this is a lot of what you've all been doing for the last 3.5 or 4 years. The Track 2 pathway is really for those practices who have really been doing a lot of more work with redesigning their practice, really looking at enhancing the IT supports for the work that you're doing in the practice. It also moves practices toward developing care processes and addressing the needs of the more complex patients in your practice. Finally, before I turn this over to Dr. Dorr, just to remind you all of the timeline for the launch of this. Through April and July, there was a whole process, sort of a phase 1, if you will, where the payers developed their applications to CMS, and after that occurred in July, the regions were chosen, and now really sort of the phase 2 of the model is recruiting practices and signing up practices for the different regions. This will occur between August 1st and by September 15th, all applications need to be in to CMS. Hope that by middle of October that the practices will be announced, and then model launch on January 1st, 2017. Yes, David.
So, yeah, and we're going to switch and start to talk about Oregon's experience in CPC. Ron, that was a really great introduction. The CPC Plus is, in a way, sort of an augmentation and expansion in many ways, the number of practices that can be involved, but also the two tracks and the way the payment is done is very different. And CPC had a similar timeline. It was pretty fast. This is perhaps even faster, in part because one of the biggest benefits, and we'll talk about this a little bit later, of CPC Plus is many of you have been reading, I'm sure with great fascination, all the changes coming from MACRA, where there's new Medicare payment reform, and there's one arm called the Merit-Based Incentive Program, or MIPS, and the others are these advanced alternative payment models. Usually when we talk to people, people really would rather be in the advanced alternative payment models. There's more opportunity for transformation, for organizations like accountable care organizations to transform the care that they deliver. And CPC Plus is actually an advanced alternative payment model. So it actually, by applying and getting into it, you have the greatest opportunity to not be in MIPS, which people are very concerned about because the fee changes that could be part of that are set at net zero, whereas in CPC Plus from primary care, there's an addition of many different ways that you're going to get paid, and the alignment is very beneficial. So being part of an advanced alternative payment model is really important to many practices, and that's something, although we won't go into great detail, it's really important. Those start January 1st, 2017. So that's why they're really pushing this program and why it may feel like you have a shorter amount of time to decide. But there's a lot of very big benefits to this, so that's why we're very excited about it. You can transition to the next slide. So we wanted to talk about, we are one of 7 regions that reapplied to be part of CPC Plus, who participated in the original CPC. And our groups have been the CPC Regional Learning Faculty here with a number of people from within our organizations as well as outside. And we've seen amazing changes in the practices and are going to have a few practices talk to you about what happened with that, why they decided to apply what they got out of CPC, and why they're excited about CPC Plus. One of the things we saw in CPC was big transformation. There are 66 clinics who participated continuously, and they have really transformed their care. Their overall measure of patient-centered medical homeness, as derived from the PCMHA scores, have increased by a third. 2/3 of them have started to engage patients and families directly in setting priorities for their clinics through patient-family advisory councils by getting their input in, understanding how the care is perceived, especially for patients with complex needs or as they're working on quality improvement. That's been a dramatic change where we've seen practices really get very excited about this. We see a big effort in the clinic's ability to do risk stratification, to identify their patients at highest risk, and to do that consistently across their entire population so that then they can provide additional care management or transitional care services as part of this, and that's encouraged part of this. And then all of the practices are offering 24/7 access to care that participate, and these are very similar requirements for CPC Plus. Go on. And as a result, and this is why there's a CPC Plus, even though we only have a few years, only 2 out of the 4 years of results, we're already starting to see big changes in hospital admissions and 30-day readmissions. And so what this is leading to is that CMS specifically is saying, we know that primary care is an incredibly important part of sort of our healthcare system transformation, all of our effort. We know that they're not generally large organizations that can take on big risks, but yet they can do so much. So we're going to make sure that they have an opportunity to really be recognized for the kind of population-based services they can provide, the kind of transformative efforts they can provide to patients. And so I think that the experience was good, the transformation was very good, and that we should really hear from some practices about their experience as well. Don't just take it from me. So I'd like to introduce Christy Sedlecki, who's at Grants Pass Clinic as their Chief Executive Officer. We call on her a lot. She's very enthusiastic, and we really asked her to talk about her experience with CPC, what she wished she knew when she applied originally, and why she's excited about CPC Plus. So I'll turn it over to her. Christy.
Hi, this is Christy. Good morning. So I was asked to talk about a few things. The biggest change to the Grants Pass Clinic since we became involved in CPC, what we wish we knew before we started, and why we're applying for CPC Plus. And we're super excited about CPC Plus, so I'm happy to talk about it. So we're an independently owned multi-specialty clinic, a for-profit, and we're we're large in Southern Oregon, but probably not by a lot of other people's standards are we large. So our biggest change has probably been moving our focus away from the physician office visit to a more of a focus on the full range of patient care. So that includes things like phone calls, secure emails, the multiple team members that take care of the patients, focusing on populations of patients and improving care. Some nuts and bolts things that we've done that represent some of the biggest change are we created a scorecard to track our quality metrics. And that's really helped us see how our changes are really impacting the real care. We also, as part of that, really reach for patient stories because it's really nice to connect not just the data, but the way that patients are really impacted on the ground. We've also, as part of that scorecard, our physician owners put a portion of their income at risk, and that really was one way that they showed that they were invested in quality improvement efforts. Another nuts and bolts way that we had some big changes was around standardizing processes. I worked in the Grants Pass Clinic in the 90s, and we had a little bit of a reputation for being practices within a practice. But now we have a lot of more standardized processes, including transitional care management, looking for ways to boost our preventive services to patients, shared decision-making tools. We have some integrated services like behavioral health, addiction services, and care manager, among many other things. So lots of big changes, but really the global change is focusing on the overall care of the patient. When we were thinking about what we wish we knew before we started CPC, there really wasn't too much. We were a little bit gung-ho from the beginning, even though we didn't know what to expect completely, because it sounded like it was just a good fit for the culture of the clinic already. Things that I kind of wish I knew. I kind of wish I knew that the resistance was going to be short-lived. I really geared myself up for having to deal with long-term resistance from the providers and some of the staff having to change the way they documented. And it didn't last very long. And I was sort of in a headset of fighting it when I wasn't fighting it. And so that was a little bit silly. And the other thing that I wish I knew was that CPC Plus was going to come along, because we always had this ongoing worry that we were going to have to cut some of our great new programs and services. So it was always in the back of our mind, what will we cut? And I think that holding back probably interfered with us fully developing some of the services, although we are still very proud of the development we've had. We're applying for CPC Plus for a lot of reasons. Basically, it supports the full range of services that make us good primary care providers. You know, when you're looking at the methodology behind CPC Plus compared to fee-for-service, which just mostly supports office visits. The process focus of CPC has made us better, and we really want to keep that going. Some of the nuts and bolts around that, again, are that we feel like what the changes we've made through CPC Classic has improved our ability to recruit and retrain both providers and staff. People are really attracted to the patient-centered, team-based care model, and I think everybody knows recruiting and retention are huge issues, and we think it gives us a leg up. Personally, I like that CPC Plus helps me continue to have a voice in healthcare delivery and payment reform. That's been my platform of 2016, is to be an advocate, and I hope to continue having a voice in the future of healthcare. And one of the things that has really benefited us through CPC Plus is the ability to network and share best practices. We learn from others, and we enjoy sharing what we've learned with other people. And there's so many more things, but those are kind of it in a nutshell.
Thank you so much, Christy. That was very helpful. We have another person to speak as well, although he was not able to be on until 8. So we're going to come back to Bill Koenig to also talk in a bit. So Ron's going to talk a little bit about the components that Christy was just referring to. I mean, that's an excellent segue.
Yeah, so as we were thinking about putting together this webinar, there really what surfaced for us with what we think are kind of the 4 major topics in the CPC Plus model. And so we wanted to share over the next several minutes, and we'll work Bill in when he gets here. But we wanted to talk with you a little bit about what's going to happen in your practice, what's actually going to change, and so we'll go through that very briefly. Obviously, you're going to want to know is how are you going to get this work paid for? What are the payment methodologies? The third thing that we wanted to touch base on is what kind of IT support will be needed. Will your practice be able to do that? Will this allow you to do this work? And then finally, we'd like to bring the payer engagement work. What will be the role of the payers as we move forward over the next several years, and have a little bit of a discussion about that. So I thought I'd just start off about what's going to happen in your practice. Well, there are 5 primary care functions, is what we're being called. So the CPC Classic folks will probably remember this as the milestones, but in the next version of CPC Plus, they've changed the terminology to the 5 primary care functions. This will be occurring over time in all of your practices. You know, for some of you, you've already maybe gone down this road to make some of the changes in your practice, so it may be more of a refinement, particularly in the track 1 folks. For others, this may be the first time that you've addressed identification of the complex patients, or risk stratify, or creating relationships with your hospital admissions or discharge team or emergency department. So these will be maybe new functions. What for the track 2 folks is really taking it, the first column there in track 1 really to another level, really sort of expanding the breadth and depth of these 5 areas, which are access and continuity, care management, where you're risk stratifying the patient population, the comprehensive and coordinated care function, which is really identifying those populations that require specialty care, addressing their needs, creating the systems that need to be in place for acknowledge or knowing when they're in the hospital, but also knowing when they get discharged. For the track 2 folks, particularly in comprehensive coordinated care, we want you to go even further with that, particularly in the area of integrating behavioral health and mental health services within your practice, really creating the integrated healthcare practice. Also in track 2 in this area, I'm particularly excited as a geriatrician to think that, beginning to think about the care processes and put in place to manage the dementia population in your practice or in your community, and creating the supports needed to take care of that population. The other 2 primary care functions, the patient and caregiver engagement, as the CPC Classic folks will tell you that this was it takes time to begin to create a patient advisory council within your practice. How do you engage and bring them into being a key informant? But in track 2, as you move through this, is how do you actually bring them into the practice and have them engaged in even some of the functions of the practice, thinking about how they might participate in your quality improvement committees and other committees that might inform your practice, but also what are the kinds of things that you might want to do to help them better self-manage their disease or processes, such as the chronic disease self-management programs and other programs. So these are all the 5 primary care functions that will be expected of all the practices. Track 2, folks, you'll be expected to do all of the ones that the Track 1 practices will be expected to do, and then some. So I'm going to turn it over to Dave. And have you talked a little bit about payment methodology?
Yeah, so one of the great things about Oregon, I think, is that because there's been a lot of experience in some of these different areas, we anticipate that we'll actually have people, a lot of practices applying for Track 2 as well as a number applying for Track 1. One of the original CPC Classic novelties or interesting facts about Oregon is we were by far the largest, the state with the largest number of practices who chose to do behavioral health integration. There was a choice. You could do self-management support, behavioral health integration, or medication management, and a lot of people did that, and that's a key function now in Track 2, that you really have to be doing that at some level. And this is really, I think, what gets people very excited about CPC Plus, is that this is the transformation work here. Historically, primary care has been working on these functions, but hasn't really received payments for those specific functions really until the very recent past. And now with CPC Plus, it's really at scale. So the payment methodology is interesting. It's a multi-payer demonstration. This is a payment methodology for your Medicare fee-for-service patients. Now, the other payers who are participating were asked for these general approaches to align, which I think is a very positive thing, but they'll have differences based on their different populations and ways of doing business. But for Medicare fee-for-service patients, like CPC, CPC Plus has this per beneficiary per month, basically per patient per month, fee or that is given to the practice for every month, every patient that's in your practice per month. So it's $15 on average. It's stratified. We'll show you that by the risk for those patients. And then in Track 1, it's $15. In Track 2, it's actually $28, and we'll show you why that's so different. The underlying payment structure for Track 1 is the same for fee-for-service. So you'll continue to bill and just get these payments on top of it and get exactly the same payments that you're getting now for Medicare, which there's a little subtlety because in MIPS, you're at risk for -4 to +4 in the next few years, up to -9 to +9% adjustments in your payments, depending on how well you do on that. So for this, you're just going to continue to get the same payment. For CPC Plus Track 2, this is really moving away from fee-for-service. There's these comprehensive primary care payments, CPCP, which is hard for me to say. And you can opt over time to move the majority of your payments into an upfront calculated amount, 65% of your previous fee-for-service payments for Medicare plus 10%. So they add 10% on, saying, you know, we know that this will be a transition period to your previous fee-for-service payments in 2016, and then you can have up to 65% as an upfront payment. And then you get less for each fee-for-service visit that you do that year, but you actually get this sort of bolus payment from the start based on your previous performance. So that's a big shift. Now might have more room to do a lot of different work in terms of the population management you do and trying new ways of engaging patients and not be so dependent on the fee-for-service payments that you're getting in, instead anticipating these bolus payments. And then there's a quality and cost performance incentive. Most advanced alternative payment models have a downside risk, meaning that you as a practice would actually take risk for engaging in it. This is actually just these payments being at risk are only basically if you fail to achieve certain quality and cost performance goals, you just won't get the payment. You're not actually at downside risk. So that's a special benefit of CPC Plus. And per beneficiary per month, if you meet the quality and cost performance incentive, which we won't go into great detail here, you can get up between $2.50 and $4. So there's a lot of different components here that are combined, but they're really all on the upside for primary care, given that those primary care functions you'll need to invest in and achieve and sort of document how you're doing. Next slide.
I'll try that. There you go.
Okay, so the tiering, and this is pretty common from previous. Basically, oh good. So as soon as I finish this slide, I'm going to move back to Bill. But let's talk about this a little bit. So depending on the complexity of patients in your practice and the track you're in, you actually receive different payments per patient. So from $6 for really straightforward, what they call low-risk patients, to up to $30. It's not. This is the non-visit-based care management fee. So this is just the amount you get per beneficiary per month. In track 2, they really changed this, and this is actually really heartening for me, and I think for Ron too, is that the average is now $28, and that's because they have this very complex tier where it's $100 per beneficiary per month. If the patient is very high risk, we're talking about multiple 5, 6 chronic illnesses, dementia, right? We know there's all the coordination that's required in that, and that really good coordinated care is incredibly beneficial, but also really expensive to deliver. And so this really gives practices that are ready for that next step the ability to invest in making sure that very top % of their practice is their care is coordinated and they have the additional services and really thinking about advanced ways of doing it. There's no beneficiary cost sharing, so unlike, for instance, some chronic care management fees or things like that, the beneficiaries really don't have a downside, so your patients aren't going to come in and saying, why am I getting this fee? And the risk is relative to regional, which I think is a good benefit here. So why don't we move back a few slides and let Bill talk a little bit about their experience at Physicians Medical Center, about their experience in CPC, what they wish they knew for CPC, and why they're excited about applying to CPC Plus.
Well, good morning, everybody. I am thanks for having me. As far as what I'd like to know before we entered into CPCI, I kind of did a little bit of thinking on that. Is that how it was going to be really in over the next 4 years, how it was going to change everything, and how much thinking we would have to put into this, because it does take thought and it takes planning. And as you get those planning stages to meet, you have to have the people that are willing to make those changes and change those plans. So going into it, to realize how much work it was really going to be would have been better to know, but at the same time, you don't want to necessarily know something so much that it dissuades you from wanting to do something different. So we're still very excited and I think we're quite proud of our clinic on what we've done and how we've been able to change the face of our clinic in regards to the patient care and how this is all taken care of here. As far as things that we've gotten out of it, I think engagement as a group. I will be the first one to admit I was a bit of a negative Nancy on this stuff, saying that I don't think this is going to work. and I don't think we should play around with this, but at the same time, I was willing to give benefit of the doubt to our administrator, who kind of said we really should probably do this. So as we all jumped in, a big thing was the engagement of the group. And even though that we still have a couple that like to kind of hold back, we got, I think, engagement as the entire group of all our clinicians as well as all of our staff, which is really important. Has played a big role. Some of the other things, the attention to primary care, and I think it's important to know that we're, you know, as a nation, starting to pay more attention to the primary care focus that we should be on instead of some of that have gone through the years. Looking back, I was part of the whole capitated system 20-some years ago, and has that kind of imploded on itself and fell apart. I think that had a little bit of a kind of tainted my idea about going towards this. But again, I think you have to look back at some of the past, and we learned from that as well. I think one of the big things that have changed our clinic is knowing that we can innovate with success, is the way I put it. And as we innovate and change things around and do things differently, we get a lot of great experiences. And one of those big experiences that we had is risk stratification. And when we got into the system of how to do that, we, as our teams, worked together to say, how can we risk stratify? What's the best way for our clinic to do that? We developed some software to do that inside our clinic. That was a big step. And I think that also brought around engagement of the entire group. It brought in the people that could actually monitor things better and find out those patients who really need more of the care than those who are, you know, that weren't as risky as you were kind of bringing up there. And the other thing that I'd like to stress in what kind of changed, I think it, and you might have to correct me, and there was a milestone in there that we needed to develop the PFAC, the Patient Advisory Council. And that has made a big impact on our clinic. Again, I'll be the first to say that I didn't think that was such a great idea, and I think that we needed to be careful about how we developed it and who we developed it with. But again, the team that took it on and decided to run with us, it has been immense to cause some change, help the group, especially the ones who weren't and still aren't quite on board 100%, to realize that patients can make a big difference as far as like how you do things in providing care. To hear some of their comments and some of their suggestions, we've taken a lot of them now and ran with it, and actually they've all pretty well so far have paid off. And we're right in the middle of another process and another program that we're doing, and we're actually used the PFAC's comments, the patients themselves, their comments on how hopefully we should be able to do this, and we're incorporating that into our plan. So I think the thing I like to stress the most is that innovation for success. A lot of the CPCI drove us to that with those milestones to innovate, create, do things differently, stress primary care, and it has been so for us, and just in patient care, our overall patient care that we offer, I feel that we've improved dramatically. So I'm a big fan of this. So it's turned me around. I'm not a negative Nancy anymore. I see things coming down the road, and then with the CPC Plus, again, enough to kind of prod you along and change some things and do things differently. Sometimes you need that prod to get you going, and once you get going, the energy is quite exciting overall. So those are my comments, and we are very excited to hopefully get involved with just as much with CPC Plus. Thanks.
Great, thank you so much. I think that's very helpful for the practices to hear a little bit of your experience. We're going to keep on with our, sort of the broad overview here to make sure that we have time for questions. We actually have our first question, and so I'm going to take a second to answer it because it's very pertinent to the slide, which is how do they do this? risk adjustment. How do they assign people to risk here? This is Medicare. This is a prospective payment, so they use hierarchical condition categories, the HCC scores that you know oh so well, to do it. It's actually interesting because the practices do their own risk stratification for who you think is really at risk, but the payments are done through risk scoring that that in this case Medicare or that the insurance carriers would do to set the payments, which I think is for Medicare is very common across all their sort of risk adjustments. They're using HCCs, and it performs reasonably well. I think we know that there's some issues, but my team compares risk scores, and it does pretty well in identifying a subset. But it's good to have the local human option, especially for adjudication. Next slide. So I'm very interested in HIT. You're probably much less interested, except maybe worried about it. So what are the requirements? Really, for track 1, you need to have an EHR. You need to get 24/7 access to that EHR, and you need to submit quality measures. Many of you may be doing this already. These are aligned so that if you submit the quality measures through this, it accounts for the quality measure submissions you might hear of for a number of other programs at the federal level. For track 2, and this has been a big concern, is there's specific language saying, hey, you need advanced EHR capabilities or HIT capabilities. Note that difference there. Some of these may not come from your EHR, but from other HIV vendors. And you need a letter. Well, CMS said, oh my gosh, practices are very worried about this. They don't think they can get their vendors to get a letter. So then now there's a gigantic PDF with all the HIT vendors who said they're going to give a letter to you. So if you look on there and your HIT vendor's on there, your EHR vendor, you're going to get a letter from them. You just need to reach out to them and ask them to get it. There's a few notable exceptions, including Epic. They're having a webinar August 15th. They said they'd do it. They just were a little slower to sign up. So we think that this will be less of an issue, that CMS has actually been working pretty hard with the vendors to say, you really need to be doing this. This is where we're going. So we can follow up with that with other questions that people have, but I'll stop there for HIT requirements.
So let me move forward to the fourth sort of topic that we identified, and then certainly one of the key components to this model is engagement and bringing in the payer community to this model. And having them as an active partner as we move forward with this. As you can see from this list is that we have 15 payers that have approved applications with CMS in Oregon. I just want to point out a couple that you might not see. First of all, let's point out that these are the CCOs and the commercial, state, and federal payers. Some of the practices might note that their CCO might not be listed there, specifically Jackson Care Connect and Columbia Pacific, but they would fall under the Care Oregon participating payer contract. So just want to point out that there are maybe other connections that you might make. I think one of the things that we wanted to do is invite Dr. Jim Rickards, who is the Chief Medical Officer at the Oregon Health Authority, just to make a few comments about the role of the payer, in particular the Medicaid and CCO group that have decided to sign on with this program. So let me introduce Jim. Hopefully you're out there and we'll connect with you. Yep. Let's see.
Yeah, he's a panelist, or he's not listed as a panelist, so Kate's got to do some magic to get his voice heard.
Okay.
Hi, this is Kate. Sorry, Dr. Rickards, are you there? Not quite yet.
Yep.
I might need just a second.
So maybe what we could do while you're trying to find Jim
Are you
out there? Is that him?
Yeah. Hi, how you doing?
There we are. Okay. Hi, Jim.
Okay. Yeah, thanks for letting me say a few words. So I think just by looking at the payer participant list, we can see that there's been a huge interest from our CCOs, which I think is just incredible. So from the Oregon Health Authority standpoint, we felt that this program aligned incredibly well with our coordinated care model. We saw that our CCOs were already doing a number of the different things that the CPC Plus program was asking for. So they were already paying a lot of the care management fees, doing the pay-per-performance type payments. So the CPC Plus program really aligned with what was already happening in the Medicaid population. In Oregon, about 25% of our state's population is on Medicaid. That's about 1.1 million people. Around 90% of those lives actually are covered by our CCOs, but about 10%, or around 100,000 of those folks, are actually covered by fee-for-service or receive their benefits directly from the Oregon Health Authority. So with that, I think folks might wonder, well, what is the Oregon Health Authority's role in CPC Plus? Well, one, we are actually a payer participant ourselves. So just as our CCOs are payers, the Oregon Health Authority itself is actually going to be a payer participant in this with its fee-for-service population. So we're going to be right there with our CCOs, and that's why we're listed as number 6 on this list here. We also see ourselves as a communicator with CMS. We have a very strong relationship with CMS and have been very involved with them in the application process to help see that Oregon was recognized as a CPC Plus state. So we'll continue to champion those communications as necessary. We also see ourselves as a convener of our CCOs, so we did work very closely with our CCOs to communicate the importance of the CPC Plus program and encourage their application, and also assisted them and supported them in the application process. And as we move forward, we hope to continue to work closely with them around this program as needed. And then we also see ourselves as an interface with the Oregon state government, so the governor's office as well as our state legislatures. They're very interested in this program. They see how it fits in nicely with our coordinated care model. And so we'll continue to work with them and our CCOs to help keep this on the radar of state government. So with that, I just wanted to make a few brief comments. And again, I'm extremely proud of all of our CCOs being payer participants in this. You can see that it really is our Medicaid payers that are the overwhelming majority of the payers in the state. So I think this is just fantastic evidence that our coordinated care model is working, and thanks again to everybody.
Great, thanks so much, Jim. And folks have questions about that relationship. Feel free to put that in the chat box or ask a little bit later. We'll really pleased that there's been so much interest and engagement from the Oregon Health Authority. I'm going to turn this over to Dave. You want to talk a little bit about eligibility requirements, and go ahead, Dave.
Yeah, so we had a question about this, so we're going to answer it right now. So you are eligible if you are a primary care practice with greater than or equal to 150 attributed Medicare fee-for-service beneficiaries. Attributed means seen in your practice in the last 24 months, generally. You also, primary care practices include providers that have specialty in family medicine, internal medicine, geriatric medicine, CMS programs that's for adults. So you need to see adults, obviously, to have that number of Medicare beneficiaries. It does include MD/DOs, NP/PAs, and CNS certified nurse specialists as the providers who could see those patients and have them attributed to them. So I think that's sort of a broad set here for inclusiveness, especially given Oregon. The clinic can be multi-specialty. It doesn't have to be a particular size. It just needs to have these specialty of providers and that qualification for 150 or more Medicare fee-for-service beneficiaries. You also need to, in the practice application that we'll go over a little bit, have some readiness in these areas: care management, patient access, and quality improvement. And you could select, it's a higher bar for track 2. You can actually select in the application, I'd be willing to take track 1 versus track 2 if my readiness is different. And that's pretty accepting of a wide variety. Unfortunately, you can't be concierge rural health clinic or a federally qualified health center. They have different payment mechanisms, and CMS just can't figure out how to sort of align all that different payment historically. Initially, there was an exclusion if you were in a Medicare Shared Savings ACO. Now, up to 1,500 practices could be in both, which is great for a lot of people, I think. So those are the eligibility requirements.
I was just going to say, we're not entirely certain whether there are any clinics out there that are in the shared savings program for the ACOs, and I would encourage you, if you are, and you know that you are, maybe you could just put in the chat box and identify yourself and your contact information, so we could maybe even reach out to you. But
yeah, I mean, we know a few because we've had dropouts from CPC because you couldn't be in CPC and be in both. So it was a big choice for a lot of larger organizations mainly. So yeah, actually OHSU is excited about this because primary care, it's very good for primary care. Being an ACO is also important to the organization. So this is a good thing. Next slide. So let's go over the application topic so you're not going in blind, and you can ask additional questions about this. Ron and I will go back and forth. So preliminary questions are pretty straightforward. We went over, the region, we talked about the tracks, eligibility, and then the participation in other Medicare initiatives. There's pretty clear language either there in the web app or on an updated version of the PDF. We had sent one out earlier, and they keep on updating it, so we're going to give you all the sites you need to go to at CMS to make sure you're getting the most recent information about all of this. So this is why we're not going into incredible detail about it. And it tells you, well, if you participate in TCPI or something, well, you can remove yourself from that by this date and still be eligible. Practice structure and ownership. There's a lot of information both on the web app about what these questions mean in terms of we get questions about TINs and the ownership types. Whether you participate in CPC is relatively obvious. Contact information, you need a letter of support from a clinical leader at your organization if it meets certain criteria. You need an HIT contact, so that's a good thing. We find for our technical assistance work, we identify those people, looking at those resources really helps you to start the transformation process so you're not sort of waiting to build up. So if you don't have somebody who works on HIT, I think that's an important question for you. Practitioner and staff information, again, the number of clinicians, there's detailed information about that. Practice activities, medical home recognition, which has come up a lot because there's confusion about what the medical home track and advanced APMs is versus being a medical home more broadly under MACRA. The CPC Plus is a medical home arm of advanced alternative payment, and the medical recognition options they give you in that list are many, including our state-based PCPCH you can put in there. So that shouldn't stop people from applying, is under our understanding. And whether you train future PCPs, because they're very interested in practices having, having PCPs, future PCPs come out and train and learn about the great work you do. HIT, whether you're EHR, you need the certification ID, and then do you plan to switch EHRs, which can be a difficult part of a program if you're a year and a half in and you're planning to switch. I don't think it's an absolute contraindication at all, but it's just something they really want to know about. Next slide. So these are more of the next two slides are more the difficult ones to gather. You'll want to gather in advance as you're applying or thinking about the demographics, race, ethnicity, and preferred language. A lot of you are doing this as part of meaningful use sort of HIT use. Practice revenue and budget. That is something, the 2015 revenue, the percent of patients by insurance type. We've received a question, for instance, that says percent of patients are Medicare. They generally mean fee-for-service Medicare. If you have Medicare Advantage patients, those are generally commercial patients in the percent of patients. But you can get the 100% answers. We're going to try and answer what we know here. We'll also gather questions and send them to CMS and get the answers back for you. You can also ask CMS directly, as many practices do, and I actually do encourage that. They have a lot of people working on this. So the letter of support is due if you are a parent of an owner organization. If the parent of the owner organization is practice is owned by a larger organization, right? And then if you're a Track 2 practice, you need this letter of support from your HIT vendor, where you really get that by looking at that PDF with all the HIT vendors. And there's some details about the letters that they're going to be expecting lots of asks for letters if they're on that list. If they're not on that list, please do actually talk to us or reach out to them. They're probably thinking about it, but just didn't have time to sign up. I don't know if you can see the apply online link. app1.innovation.cms.gov/CPC+. It's a web application, so whatever's in there are the official application questions. So there's some differences between the PDF and this. Any sort of specific care delivery options, Ron, that you people may be very interested in what they ask around here?
I don't think so. I think it's pretty straightforward in terms of the readiness and in terms of where you're at, and particularly around the 5 functional primary care options. And they'll use that information to help determine whether you'll be eligible for a Track 1 or a Track 2 or not. But I think in the interest of time, we ought to just move forward and cover this last slide and open it up.
Yeah. So there's some next slide. So there's additional questions about the no overlaps, other CMS programs, the ACO, satellite offices. These are really brick and mortar clinics that they're interested in as individual participators in CPC Plus. Next slide. And then we have these available for all you. This is really where you need to go for like official answers. We wanted to have an Oregon webinar to say that there was excitement from Oregon about the alignment and our experience in CPC. They update these frequently, and so anything you might have gotten from us, like I said, may be updated here. I just, during this webinar, got an email from CMS saying you're sending out old material, and I want to make sure that everyone knows that there's it's always updated, and the web app is the official set of questions. We do try and get updated answers and are clear about that, so you'll have this. Next slide. And we also, in the information, they're going to provide regional technical assistance, again, including maybe more down at the community levels, which is why we're excited about, for instance, CCO participation or community participation, because we found that sort of sub-region of a larger region, in this case, really helpful. All of our groups are really working together here to provide technical assistance for the application process here. There is no official TA nationally or regionally for this effort yet. That'll be announced later, but we're really trying to help y'all apply, encourage you to apply if you find it in your interest, and so that you're fully informed about it. So we're available. Next slide. And so we do, if you have any questions, type them in, and there's one more slide with our contact information, and we'll just leave it on this. If you have questions that you don't want to ask now, you can email us or talk to us. Any other questions that are on here, we'd be happy to take. We scheduled 90 minutes for this, right? So we do have some additional time for questions.
All right, so this is Kate again. If you have questions, you can write those into the questions pane in your GoToWebinar control panel. Many of you seem to find it this morning because there are bunches and bunches of questions. So there are a series of questions related to the payer, so I tried to group some of those together. Is there someone noted that Regents was not on the list, but that they had heard that it was possible they were going to participate, and wanted to know if you knew either way or could speak to that.
I don't have any information really about that, or any. David, do you know? Or
no, we've worked as part of the recruitment effort. A slightly larger group of TA people have worked to try and literally engage every payer. I actually want to thank Jim Rickert, who was pretty active in that process to get as many people involved as possible. Yes, it's true Regents is not on that list. I don't know if there's still an opportunity for them to apply, but that's something we can find out or sort of ask Jim or others who might have a little better insight into that, and send out some information about it. I'm looking at the local CPC team. Do we know anything else about that? No.
Hey, David, this is Jim here, and I know that there is some potential interest from them, but I don't know if they've now tried to officially submit an application. We have actually heard from a few other payers in the state that they might be interested in applying late, so we're trying to communicate with CMS what the opportunity around that would be. But as of now, it's just the payers on that list that you shared earlier that are definitely in. I don't know for sure if any latecomers will be accepted or not. So.
Great, thanks. That's very helpful.
And then another payment-related question: will the Oregon payers model their payment structures along CPC Plus? So understanding how it is for Medicare, but with Medicaid and commercial plans, are those going to be aligned with CPC Plus?
Yeah, Jim, if you can step in there. The application itself for the payers, which is available, asks these questions for it, and they basically are indicating the expectations along alignment. So yes, there's expectations of alignment, but broadly, I would say that they really did want to make sure that as many payers would participate as possible, and so I think that meant leaving some flexibility in the way that alignment occurred. Perhaps if you talk to the payers, they might feel like there's not enough flexibility, so maybe they hit the right balance there. But I know at least that the idea of the care management fee is supposed to be the same.
And pay for quality. So I encourage you to look at, if you really want to look at kind of the criteria for the payers, it's in the RFP, application RFP, and I think it's Appendix A, where they will actually sort of outline what the expectations were for the payers. But I'm going to ask Jim if you wanted to comment about that.
Yeah, well, I think David summed it up well, that that CMS was looking for general alignment with things around being able to pay a care management fee, being able to pay a performance-based incentive, but essentially each payer brought more or less their existing models or proposals to the table that had those elements in them. So those specific elements, so what the exact care management fee dollar amount is, or what the performance payment dollar amount is, or even what the metrics are not going to be identical amongst the payers in the beginning. At least that's my understanding. But I think the hope is that over the course of the 5 years of this program, as we have the different forums to bring people together and this platform for working together, that we can start to move more towards common alignment. So, I don't think all the payers are going to be identical to begin with. They're going to have those common elements, but we'll have the opportunity to start to align and hopefully bring these different models closer together over time.
Yeah, I think that's probably the biggest thing I heard from the payers that are participating is some alignment over time, so that we have more standardization and can sort of operate so there's not so many voices around it. It's a good opportunity, especially given right now that the state is going through a primary care payment work group, reimbursement work group, and so I thought the OHA really took great leadership in saying this is the kind of thing, CPC Plus is the kind of thing that we think would be right for that kind of transformation for payment, and sort of that was very helpful, I think, to get the payers to say, oh, okay, this is one less worry for me to think about changing how I'm going to pay primary care based on the state-based process. Now I can look at some criteria and it's out there, I have it earlier, and I think that's very encouraging for future alignment. Other questions?
Yeah, so I tried to gather together some related to participation, and I suspect that many of these are probably covered in some of the CMS materials, but can you speak to whether participation is at the clinician or the clinic level? Are there a minimum number of patients that from participating payers that a clinic has to have in order to be eligible? And what about folks who are not doing meaningful use?
Yeah, okay. So there's a lot packed in there. So it's at the practice, the brick and mortar practice level. So you really need to get all the providers at a brick and mortar practice to apply and agree to do it. And the minimum requirements are at that practice level of 150 Medicare fee-for-service patients. What percent of your practice is covered under the plans, or the revenue that's covered under the plans? Historically, and I don't know that they specifically spell this out. Maybe we can sort of look at this. I don't think they do. So historically, they wanted it to be substantial enough. So let's say you have 600 practices all that apply, and they all meet the 150 beneficiary requirements, but there's only spots for 200 or however many. Then they're going to be, I think they'll have the authority to look at some of those, what percent of your practice would be covered overall, because they see the more patients that are covered for your practice as a more transformation oomph, I guess, for this. That's sort of the informal CPC sort of approach to this. But there was wide variation, really, because of some variation in the payers that participate in CPC, and I can't imagine it would be any different for CPC Plus. So no hard and fast that we've seen. We can take a double look about number of practices required. And then what was the final part of that?
If folks who are not participating in meaningful use are eligible.
Oh, yeah, that's a good question. So I'll tell you that this is, in general, they've expected people to agree to, so there's no, here's a way to answer this question. The requirements of CPC Plus are now sort of bundled into what meaningful use will become, right? So you're applying at a phase when you need to have a certified EHR, and you're going to have to show that you use it in certain ways for this. So probably that's more, if you're not planning, if you've never done meaningful use, I think we can look that up and see if there's any information, or maybe we should gather that question. What they've done in the past is they've sort of expected that you'd be, since they were parallel before, that you'd be doing meaningful use, right? That was a milestone. Now, since they're combined, you need to have the mindset for sure for the future that you're going to do the kind of meaningful use tasks that you might have done before, but now it's evolved into this. You know, meaningful use still exists for like Medicaid and eligible hospitals and other things, so it's a little bit confusing. You really mean Medicare. They're not applying for Medicare meaningful use, I think, in that case. But we can look that up. I would sort of look at your philosophy for not participating and see if the requirements for this program also are something that may feel like a high bar for you for EHR requirements and having the certified EHR.
Okay, another question about, will quality scores apply for all patients or just patients who are covered by participating payers?
That's a good question. In general, for CPC, it's been whole practice submissions, and they haven't calculated across your whole practice. They're very interested in whole practice. That's why it's a multi-payer demonstration. And In fact, I mean, like all of the functions are supposed to apply to your whole practice, whether they're covered or not. That's a sort of fundamental aspect of this, and the hope is that you have enough that you know it sort of benefits the whole health system infrastructure, even when your patients aren't covered by the CPC payment. There's a lot of details, and I want to be cautious that we don't know every element of this program as it's rolled out, right? So I can tell you what happened in the past, and I anticipate that would be similar, but you've got to continue to look at the facts and other information, and we can ask for clarification about that over time.
Okay, a couple of questions about Medicare Advantage plans and whether or not they're counted in the minimum of 150 Medicare patients.
They're
I think
not.
you may have already. Yep. Okay.
Yeah. This is a little bit of us reading very carefully, but in general, Medicare doesn't have any sort of authority to give payments for those patients, so they mean 150 fee-for-service patients.
Yeah, as part of the eligibility requirement. It doesn't mean that the Medicare Advantage plans that some of the payers that will be involved, those patients will be involved in the practice and in those changes.
Right. So you see, there's some commercial payers. The commercial payers have a Medicare Advantage, and the Medicare Advantage is participating line of business for CPC Plus. Those patients actually will get care management fees according to that payer, but for eligibility, it's fee for service.
And then a few questions about the risk stratification and the tiers. I think you touched on this, but could you talk about how that's determined again?
Sure. It's basically Medicare calculates the hierarchical condition categories, which is a score that's normalized to 1.0. Nationally, historically, although now they say they're going to do it regionally, which is way better for Oregon because we do not have a history of having really carefully done HCC conditions in our billing, unlike some other states. So those scores are calculated basically by patients' chronic conditions. They create that by looking at how much patients cost over time. They actually adjust their payments for that. And then they spread those costs out exactly as you saw that sort of breakdown of the lines of track 1 and track 2 in these groups. They sort of spread them out. So if you're in track 2, it's 10% by region of the most at-risk patients will be in that top category, basically. So every patient gets a risk level from HCC scoring that Medicare does, and then that's how your payment is calculated. Historically with CPC, that you've actually submitted, here's all the patients that I think are in my practice, or the list, or you've been able to sort of edit that list a little bit, but they attribute them and do HCC scoring on them, and that's how the payment is done.
I was just going to make a couple of comments about that. One thing that the HCC risk stratification methodology does do is it drives you toward doing coding and making sure that your coding is accurate in your practice. And for many practices, that it can be an improvement process in and of itself. The other thing about the HCC coding, although good or bad, is that really you're talking about past information about certain patients, and a lot of what we want to do is to prevent things from happening. And so that's where it's going to be really important that you design processes in your practice, not just to respond to the HCC coding risk stratification, but also to think about, well, what population is that vulnerable population that could then get into some of these tiers and makes it and that you want to address that population in the future before the horses get out of the barn.
And that is an active, like your own risk stratification of who you think is important to focus care management services on was a huge part of CPC. They didn't say take the HCC scores and only focus your efforts on the highest risk population by these scores. They acknowledged this gap, temporal gap, the lag, and said you develop a way to risk stratify your entire patient population, and you work to try and identify those future risks we might not have seen yet and mitigate those so that overall you will reduce improve the health and well-being and reduce the risks for those patients.
Great, thanks. There was a question about how folks will know if they meet the cost benchmark.
Yeah, so like if you're talking about the $2.50 to $4 per beneficiary per month cost element, I don't know that that's all 100% clear here yet. There is some information about it in some of the materials, and we certainly can point you to those. I would actually hesitate, based on our experience with shared savings in CPC, which this is not shared savings, but a similar idea of providing additional payment for meeting certain benchmarks. I think that we need to, in general, their approach is to sort of reward meeting of getting a composite score that rewards meeting a number of benchmarks related to quality and cost.
Yeah, my understanding is that the quality measures will be primarily kind of the three areas. One would be utilization, so there will probably be some kind of a utilization measure. The second is using patient experience of care. I think they used CAPS, didn't they, for in CPC Classic. And then the third is a outcomes measure types of reporting. Actually, the patient-reported outcomes measure I think is just for track 2. But looking at those three, there will be a deposit that I'm not even sure that they've even chosen all of the ECQMs or the measures. I think that that was going to be rolled out this fall.
Okay, so there was a good question, a couple of questions actually about reporting requirements, especially as related to spending. Can you talk about what will be required to submit in regards to reports, requirements, metrics, and things like that?
Let me answer this from a high level. In general, if you're used to a fee-for-service world where you've got your codes down for all the visits you're doing and procedures you're doing, and do very little reporting outside of that, then this will be a shift for you because they do expect regular reporting quarterly about a number of activities that you're doing, including some quantitative, historically, for instance, risk stratification, what percent of your patients are risk stratified, what percent of those are receiving care management. We don't have that web application for the new CPC Plus, and they reserve the right to sort of figure out the questions that will best meet these functions so that they can understand them. A very general sense of the application are those are the kinds of questions they tend to ask, but they do expect these sort of quarterly reporting. And I don't know, Christy or Phil, you could actually comment how much time it takes for you to do the quarterly reporting. I think people invest in spending some time doing that. It's not, they don't use their whole budget for it, but if you have comments, that would be helpful.
Hi, this is Christy. We have a QI coordinator who does our quarterly reporting, so it's part of her job description. And she spreads it out over time. So I have to say I'm honestly not sure of the exact amount of time, but it's not overly cumbersome for her. She has plenty of time to work on all of the quality improvement things we do internally besides reporting. As far as the budget reporting, it just gets easier every year because once you do the first one, you have an idea of how to do it, and it's quite a bit easier. Does that help at all?
Yeah, I actually want to sort of expand. It does, because a lot of people do hire a part or full-time person or create time for a person to be their CPC Plus coordinator to make sure they're on top of all these things, engaging in them. They often have a QI role. And so if you don't have anybody who does that, smaller clinics, you know, it's often not a full person, but that is a designation because it's a responsibility. We've actually found that clinic and practice managers are very helpful in identifying the staffing needs and making sure this work gets done. That providers, it's important to them for the global outreach, but you know, there's a lot of sort of gathering information from different places and putting it into, or developing some reporting around it.
All right, were a couple questions. What was that?
Kate, this is Ron. So before, I know that we're getting toward the end of time and we have time for a couple more questions, but before people start drifting off of the line, one of the things that the team here would be really interested in is knowing whether any of the practices out there, or folks out there on the call today would be interested in a webinar that really focused specifically on track 2. There will be a survey that will come out afterwards that Kate, you'll tell folks about, but before people drifted off, if you do are interested, if you could just put that in the chat box, and we'll have a record of how many folks would be interested in something that might be to that track. So let us know in the chat box.
Yeah, that's helpful. The post-webinar survey that pops up after you leave will ask you that question, and it does notate your response connected to your email address. So we'll be able to reach back out to you specifically if you answer that question about whether or not you'd like to participate in a webinar about track 2. So that's really helpful. And I also want to reassure everyone that your questions did come in tied to your email address. So if we didn't get to it today or we didn't cover it exactly, you can chat it in right now again. If you really hope to hear it read over the line in the last couple of minutes, you feel like you will feel unresolved if it's not, but also know we can get back to you via email to address your specific question if we didn't get to it. So there are a couple of questions about whether folks should apply if they don't meet sort of the recommended 50% of their patients or their revenue, coming from CPC plus payers, which apparently someone read in the materials was makes the practice a compelling fit, or some not very specific phrase, whether they should still apply. And then another question about if a CCO is requiring or encouraging participation of a practice, do they need to apply?
For the second question, that's an interesting, I've not heard that. The first question is, yeah, I tried to address this as best I could. It's not a hard and fast rule, but it might be a good benchmark for you to sort of take a look at how much of your revenue is actually covered by the set of practices. My guess is it's going to be pretty close, and part of this may be difficult for you, right? Because we have risk-accepting entities like Care Oregon who are representing a lot of CCOs, especially in the Portland metropolitan area, that I tend to, unless the application just feels so difficult to do, I would tend to encourage people to apply, because they wanted 20 regions, there's only 14. They still want to try and reach the 5,000 practices, so this is much bigger than CPC. Oregon's not a huge state, as you know, and so I think that they've been actually sort of flexible about some of these elements to encourage participation, and I would encourage people to apply.
Yeah, and I think in Oregon, I think we want as many practices that are interested, that could meet the eligibility requirements to apply, so that they all have the opportunity to learn from each other and to move forward together with this. So I guess I would encourage folks to apply.
And then the CCO question you said is like a CCO is saying, hey, you really need to do this. I don't think they have, I mean, Jen, maybe if you're still on, you could correct, but I don't think there's some expectation that there's authority to require practices to participate. We think you should do it globally. Like, as a private citizen of Oregon, I'd say that it's a good opportunity.
Yeah, David.
Yeah, I think the message is apply. Oh, sorry, was that Dr. Rickers? Were you trying to jump in there?
Oh, yeah, I was just going to say, I'm not sure what that authority would be, as you were kind of referencing, David, but, you know, I think the idea is that the CCOs already have a number of the different payment elements in place with their provider networks that are going to be included in CPC+. So if you're already contracted with a CCO, you know, you most likely are already involved in a payer arrangement that's similar to CPC+. With your CCO. So I guess I would encourage the conversation to happen at the local level to see if you have some issues with the current payment structure and how it might change or could potentially change under CPC+, and then make a decision based on that.
Great. This is Kate. I know there were a couple other questions that we didn't get to, but like I said, they are captured and we can follow up via email. Thanks, everybody, for joining. I don't know if our presenters have anything else they'd like to add.
No, thanks.
No, thanks, everybody.
Thank you.